because I have gone through a whole review before and didn't record it. And I was so angry with myself. I had nothing to post. Alicia Clark, is that you? Alicia Clark? All I see is Alicia.
Could be logged in twice. Something's going on with my computer.
Oh, okay. What is your last name?
Good night.
Good night. Oh, that's you. Yeah, I see you here twice. Okay. Trying to get double credit for showing up for the review. We'll give everybody a couple more minutes to show up, but we want to kind of get started on time if we can. Because I know all y'all got other things you need to be doing. If you would sign in for me in the chat so I can have a record of who your instructor is and who you are. So I can report that, because we do take attendance for coming to these reviews. Okay. I'm going to go ahead and share my screen. And welcome you all again to our review for exam 1. Does everybody understand how the exam is going to work next week? You'll be taking it in class on Zoom with your instructors at your regular class time, unless you're taking it on campus for some reason. So just show up for your class, like at your regular class time. Welcome, Margot.
Hello.
If you would sign into the chat with your instructor's name, please, as well as your name, so I can keep up with our attendance. So this is our exam 1 preparation. Everybody probably got a copy of the PowerPoint already, so you can kind of follow along. Feel free to pop in with questions as we go along here. General questions for pediatric review. The first few are general questions like Erik Erikson, the first 5 stages of his developmental theory. Do you remember what they are, or would you have to look them up? I would have to look them up. I'm just kidding. What do we talk about when we think about the infant and Erik Erikson? Anybody remember? Let me help you out. How about trust versus mistrust? That would be birth to 12 to 18 months. And that's when all of the baby's Maslow's hierarchy type needs are met, and we don't make them wait for it. So we get to them as, usually as soon as we hear them whimper or the cry, we go and we take care of all their needs. Autonomy versus shame and doubt is 18 months to 3 years. That's the potty training stage. Feelings of independence lead to a belief in themselves and their abilities, and they strive as toddlers to please the parents. So they want to be potty trained, most of them. Some, you know, always gonna have that difficult child. Did I introduce myself? In case you don't know me, I'm Professor Morris. I'm sorry. Initiative versus guilt is ages 3 to 5. Self-confidence, the ability to take the initiative and make decisions. But this is the preschooler. What we remember about the preschooler is that they take the weight of the world on their shoulders and feel responsible if they have a bad thought about somebody, and then something bad happens to that person, they feel responsible. So they really start to develop a sense of moral feelings about things. And then industry versus inferiority, we talked about in this week's lesson. That's the school age child. They say here 5 to 12. We taught in class today 6 to 12, but feelings of pride and accomplishment. This is an age where they like to please people. They like to form groups with their peers and do things together for the society and social networking, like church groups and school projects and stuff. So their peers are very important to them in the school age. Identity versus confusion, we also talked about today, as 12 to 18 years. A strong sense of identity is what they're in search of during adolescence. So they're no longer focused on the here and now. They're focusing on their future and what they might want to do when they graduate. Hopefully they graduate. And are they going to college? Are they going to get a job? Are they going to take a tour of the world because they're rich and have, you know, all this money to spend? Not likely. But, you know, they start focusing on their future. Sigmund Freud's theory of development. What a handsome man. The cigar could go, though. He believed there were 3 parts to the personality. The superego, which is the good angel on your shoulder, and the id, which is the devil on the other shoulder. And then the ego forms because you learn to control the superego and the id and, you know right from wrong. So he was probably on track with that. So I'm just afraid that Freud he'd have a hard time accepting how much things have changed since he came up with this theory. Humans are so free-spirited now, you know, this time and date. Some parents raise their children to just be free spirits and do whatever they want to do. And, you know, there's no boundaries, and they're just expressing themselves when they're running like crazy little wild animals through the restaurant. Make them sit down, you know, other people are here. But, you know, that's the way some people are raising their kids now. No boundaries. I think of them as free-range children instead of free-range chickens. Sigmund Freud's psychosexual stages kind of makes sense if you think about it. And if you read more about his theories, the oral stage, 0 to 1 year, they're nursing. They're drinking from a bottle. Everything goes in their mouth. Children derive pleasure from oral activities, including sucking and tasting, and they like to put everything in their mouth. And then the anal stage, the potty training stage, is 2 to 3 years. The phallic stage, 3 to 6 years. Boys are more attached to their mother, while girls seem more attached to their father. And then the latency stage, 6 years to puberty. The children spend more time and interact mostly with the same sex peers. And then the genital stage is beyond puberty, where individuals are attracted to opposite sex peers. Or in this day and age, it could be same-sex peers. You know, they're going through that gender identity phase, trying to decide what they want to do. Then Lawrence Kohlberg is your moral developmental theorist. Children acquire moral reasoning in a developmental sequence, and he has 3 developmental stages. The pre-conventional level, it's culturally oriented to the labels of good and bad and right and wrong, and that there's a consequence for doing something wrong. That's ages 3 to 7. That's what you need to remember about ages 3 to 7, the pre-conventional level, right and wrong and consequences for their actions. And then the more school age conventional level, these children become concerned with loyalty and conformity. They learn now that there are rules they have to go by, that everybody has to go by, and so they have to conform. There are no longer preschoolers who can change the rules of the game in the middle to suit them, you know. Post-conventional level, that's correct behavior that tends to be seen as general individual rights accepted by society and adults. That would be us, post-conventional level. This is just another picture that may spell it out a little bit differently. The pre-conventional, age 3 to 7, moral reasoning based on reward and punishment. So that's self-interest and avoiding punishment. And then conventional level, 8 to 13, moral reasoning based on external ethics, law and order morality, and good boy attitude. Post-conventional, that's adulthood, moral reasoning based on personal ethics. And there we should have principles and social contracts. Excuse me. Play, different types of play, very important to the child. They learn a lot from play. The onlooker play, if something attracts their interest, then they're going to stare. This happens more with younger children because older children know that it's not polite to stare. So, solitary play, the child is playing with blocks alone in the corner. Is that okay if they're playing alone, not playing with the other children?
No.
Depends.
We like to see them socialize, but you know, sometimes maybe they're just not feeling like socializing. So if it's happening all the time, then that might be something to look into. Yeah.
So that's normal if it's happening like one time?
Once in a while.
Once in a while, okay.
Some children are just not social. You know, you have other little children who are social butterflies and walk around talking to strangers, and they just want to be in everybody's, you know, business in the playroom. So, and other children would just rather play by themselves. Parallel play, 2 or more children playing with blocks near each other, but not talking with each other. So they're playing side by side, but they're not really interacting. Associative and companion play, though, 2 or more children are playing with blocks, building the same thing. They're talking with each other, but they're not working together to create something. Cooperative play, 2 or more children are playing with blocks and building the same thing, talking with each other and working together to create something. So they're cooperating to create the same thing. So play allows children to use their creativity while developing imagination, dexterity, physical, cognitive, and emotional strength. And play is important to the healthy brain. It's through play that children at a very early age engage and interact with the world around them and become more sociable. Therapeutic play is used to help meet the emotional needs of children who have an illness or surgery that requires hospitalization. In some hospitals, it's used to introduce the child to what kind of procedure they might be fixing to go through or what they're going to see after the procedure. So being in a hospital is very stressful to children and their families. And sometimes children feel scared and confused and out of control. There's a child life specialist that works in the hospital with the children. It's a bachelor degree program. And they work closely with the children and families to help with emotional support and give them age-appropriate toys to keep them distracted and play with. And they have a background in child development, psychology, and counseling. And the child life specialist helps explain medical jargon to the kids and prepare them for procedures. Demonstrating on a doll helps them understand what they might see in a procedure or after surgery. They may be coming out of surgery with an NG tube in, or have oxygen in their nose, or they might end up with a trach. So they may teach them about these things in advance of what they're going to see after the surgery. When you're assessing a patient with allergies, we want to describe the reaction. Has the child ever had a reaction to any over-the-counter or prescription drugs taken in the past? How was the medicine given at the time? How soon after taking the drug did they have a reaction? How long ago was the reaction? And did someone tell you that it was due to a medication? Has the child ever taken this drug again? If so, what reaction did they have? Do you tell doctors and nurses about this reaction every time asked? So if your child had a reaction to penicillin, would you ever give them penicillin again?
No.
Well,
I mean,
you probably
It
shouldn't.
depends, we want to make sure that's a truly allergic reaction.
Okay, but
Before,
if the parents were told that this is a true allergic reaction to
oh no, you
penicillin,
don't want to, no. Can
are there other drugs that are in the penicillin family that they should also avoid?
No, yes.
Yes.
To avoid
Yes.
that.
Amoxicillin,
Mhm.
yeah, a lot of different drugs that they may still have a reaction to. Does penicillin tend to run in families, the allergic reaction?
Mm.
So if the mother was allergic to penicillin, could it be that her children may also be allergic to penicillin?
I believe so, can be, and
Yes, it can happen. Yes, it can run in families. So like I have one son that has had an allergic reaction to penicillin. Cultural differences when doing a history and physical. We want to ask about their culture and what you can do to make them more comfortable and relaxed. Discuss their preferences like food and staff. So if they have a particular dietary requirement, then we need to get the nutritionist in there to talk with them. Somebody from the kitchen who can make sure they get the right things. Some cultures only allow female caretakers and no males. So we have to arrange for that because that's their custom. Some cultures never completely disrobe for a procedure or examination. So we got to work around it. We want to use questions to assess the child's needs. If you're talking with the child and they understand English and you're conversing with them, if they're old enough, say they're a teenager, can we talk to them rather than the parents?
Yes, you can talk to them.
I think we should talk to all of them, yeah, if possible, and get the child's preferences if they're old enough to express things to us. That would be great. How do we, I guess every hospital is different, how you would get a hold of an interpreter if you needed one. Can you use a family member as an interpreter?
No.
No.
Hospital certified translator.
Mm-hmm. So they have machines in a lot of hospitals that they use as it's an interpreter machine, I guess. I don't know what you call it, but it works. Or they have a line you can call where you can get somebody on the line that speaks their language. But it's not, for HIPAA's sake, it's really not cool to let the aunt or the brother or sister, somebody else besides the parents, interpret for you. Assessment of the child, we're going to talk about that now. And these things should be included when you're doing your physical assessment. Think about physical assessment. You're going to do vital signs. You're going to do their height, their weight, their length, their head circumference. If it's an infant, all of that would be done. And then we want to document the review of all body systems. And that's it. This is what we need to include when we're doing a physical finding assessment on the child. Growth at any age. A healthy diet helps children grow and develop properly. We use the My Plate as opposed to the food pyramid now, like we used to use. We learned today in class that 17% of children in this country are obese. That's too much. That's too high. Nutrition is the single most important influence on healthy growth and development in children. And we all know that infants double their weight by 6 months and triple their weight by 1 year. Now that's just the gold standard. If you had a baby who was 2 months premature, you're going to have to make an adjustment for that baby. They're not going to gain weight and double their birth weight necessarily by 6 months because they're already 2 months behind. So what is the number one cause of obesity in the country that people blame it on anyway? May not be true, but
Food.
fast foods, too much junk food and fast foods.
And then the sedentary lifestyle where the children just play, video games
Playing
and they're
those
looking
games.
at TV, not really doing anything
Yep.
active.
Yeah, not being active. When I was a child, we used to go out in the morning and we weren't allowed to come back unless we had to go to the bathroom or eat. And that's the rest of the time we spent outside. We stayed outside all day. Frequent assessments in childhood. Why would we want to do frequent assessments, especially in infancy?
We can catch any developmental problem at time. and we
Yeah,
can address it.
developmental assessments need to be done frequently. We set our sights on the milestones that an infant is supposed to do in the first year, especially. And we expect them within reason to meet those milestones. If they don't, if you've got an 8-month-old baby who's never rolled over from back to front, that's a problem. They should have been rolling over by now. They should be sitting alone at 8 months. So yeah, that's something that needs to be looked into. So we want to go to early intervention, prevention, and make sure that they're doing an assessment on them and find out if there's something wrong. So assessing the abdomen. We're going to inspect the contour and symmetry. Symmetry should be equal. We're looking for hernias, peristalsis. Should you be able to see visible peristalsis in the abdomen?
If they are really thin, maybe.
If they're very, very thin, yeah.
Yeah. Do you mean
Normal, normal healthy child, you wouldn't. Except unless they have pyloric stenosis, which we'll talk about in GI. Oh, got a frog in my throat, sorry. Gotta drink some water. So we're gonna auscultate for bowel sounds in all 4 quadrants. What are we listening for?
bowel movement?
So
They're hypoactive or hyperactive.
we should hear some gurgling,
Yeah.
some kind of noises.
I had a question early, Professor Morris. In a regular adult client, we start on the right lower quadrant, right upper, left lower. In a child, we still doing the same routine, or we can use?
I don't think it matters as long as you cover all 4 quadrants.
Thank you.
I don't think this is in any particular order. And then percussion would be done for experienced examiners, like you're looking for organomegaly, enlarged liver and spleen, masses, fluid, and flatus. And then palpation, we're feeling for lesions, cysts, enlarged liver and spleen. And you can do palpation superficially or deep. The more experienced physicians and practitioners would do the deep palpation. I never felt really comfortable doing that, just superficial. So our cardiac assessment is going to include where we listen for heart valves. The aortic, the pulmonary, the tricuspid, and the mitral valve.
The mitral.
For
So
all
the-
of them.
The aortic valve, you're going to hear at the second intercostal space, right side. Pulmonic valve, second intercostal space left of the sternal border. mitral valve, fifth intercostal space, mid-clavicular line, and tricuspid valve is the fifth right and left intercostal space, close to the sternal border. That information came straight out of your books.
So I wanted, can you go back to the
Sure.
cardiac again? I'm sorry.
That's okay.
Now, the mitral, I know how they got it listed here. Is that the order it goes? Is the mitral valve usually last as far as you going in order? Like a order on the right, on them is the left,
Yeah,
then tricuspid, and then mitral.
we usually end at the mitral valve.
Okay, so it's in, so instead of it being the, so you said the mitral valve you end is the end,
Yeah, let me go back.
is the
one
very
more slide.
last one.
We
Yeah,
we
right
want to end at the apex of the heart, because
Okay.
that's where we usually stop and count the heart rate
Right.
when
The
we're doing our
tricuspid and
assessment.
the mitral, they are pretty much in the fifth, but the one is more center and the other one is more sternal.
Yes.
But
yeah.
you end on the mitral because that one you should listen for a full minute because that's the maximal impulse. So
Right.
Exactly.
And I
Very
guess I
good.
got kind of confused because I'm used to seeing the herbs point, and I guess that's for the adults. So it's
Yeah,
not
we don't really
Mention
do
it,
the herbs
yeah.
point.
that
With the-
confuses me too, because when I look at my points, the tricuspid used to be on the 4 on the adult, and now it's on the either 4 or 5th. Kind of.
Well, you got to remember we're dealing with children, so it's going to be a little more condensed and closer together there. So breath sounds, we're talking about tracheal breath sounds, which would be where I have my problem up here. Bronchial breath sounds, bronchiovesicular breath sounds, and then vesicular breath sounds are pretty much heard all over, except for in 2 places, which we'll see right here. So bronchial breath sounds are heard over the trachea near the suprasternal notch up here. Bronchiovesicular sounds are heard over the manubrium in the upper intercapsular area where the trachea and bronchi bifurcate, where they split right there. And then so vesicular sounds are heard over the entire lung surface, except where the bronchovesicular sounds would be heard. And then adventitious sounds are not necessarily heard over the chest. Where are you going to hear them then?
In the back, maybe.
Mhm.
In the scapular area, you can hear them, or at the
You can-
base.
Yes, sometimes you can hear a baby breathing if you put the stethoscope on the stomach. You can still hear the breath sound. So that's not necessarily on the lungs when you're listening, but you're hearing breath sounds still in different places. Car seats. What do we need to know about car seats? Well, they've changed a lot over time.
They have expiration dates.
Yes, they do. It may not be stamped on them or something, but you can find out. Car seats have changed rear facing in the back seat of the vehicle until 2 years of age. Then front facing in the back seat. So properly installing a car seat, the short answer to expiration dates on car seats is maybe, maybe not. In general, car seats expire between 6 to 10 years from the date of manufacturer, because laws change governing the manufacturers. And you can see more about this at this website right here. So we can learn about car seat safety at the National Highway Traffic and Safety Administration, the United States Department of Transportation, local fire and rescue should be able to help you out with that, and parenting classes. Vaccines for STIs. Currently, the only 2 that, that have vaccines are hepatitis B and HPV. So Hep B should be given at least 12 hours after birth, and then 1 to 2 months as an infant, and again about 9 months of age. The HPV vaccine can be given to girls beginning about age 9, and it's also recommended for girls and women aged 13 to 26 who have not yet been vaccinated or completed the vaccine series. The HPV vaccine also has been found safe and effective for males. ages 9 to 26 years. Let's talk about the baby. Anticipatory guidance for parents. Let's see that little tooth coming in there. And then we got 2 toothies. How many teeth should a baby have by the time they're 6 months old?
Like 4, maybe less, maybe more.
A lot of them have 4. But you know, some babies are slower to cut teeth than others. But beginning of tooth eruption varies, but it's generally about 4 by the time they're 6 months of age. So the head lag when pulled to a sitting, you know, when you pull them up and their head is leaning back, you still need to support their head for as long as needed. They're able to sit for long periods when the back is well supported. They can roll from front to back around 5 months and from back to front at about 6 months. When they're supine, they'll put their feet in their mouth. Well, we can't do that anymore, can we? They can grasp objects at about 3 months if you put it in their hand. That's called the palmar grasp. And they put everything in their mouth, including their feet. They pull to standing about 9 months. Oh my goodness, my voice. Excuse me. And they sit unsupported by 8 months. What is colic?
Is any pain or crying? I got the 3 rule, 3 hours, 3 days a week, for 3 weeks. They just go away around 3 months, depending on their PrEP or no. If you have more than 8 hours respiratory pain, you should go to the emergency room because something else.
Yes. Excuse me. So how do we treat colic?
Depends what causes it. Sometimes can come from the milk. Mine was formula feeding and he was allergic. So everything, every formula that I tried, yeah, colic. So
Oh,
yeah.
Poor baby. So yeah, she's right. Colic is when an infant who is not sick or hungry cries for more than 3 hours a day, more than 3 days a week, for more than 3 weeks. The conditions, it's a bit of a mystery. They still don't know exactly what causes it in some cases. So colic is likely to start around 2 weeks of age if the infant was full term, or it can be later if they were born premature. It almost always goes away by 3 or 4 months of age, but for you, if you have a baby with colic, it can happen regardless of the baby's sex, birth order, whether they're breast or bottle feeding. If you receive a phone call about an infant that's crying for more than 8 hours a day, we can't just assume that it's colic. So they need to come in and be assessed because there may be something else wrong with them. Developmental periods. These kind of make sense when you think about it. Sequential trends involves a predictable sequence of growth and development stages where the child normally passes. Those are our normal stages we expect a child to go through in a normal sequence. Like they might crawl before they creep, and then creep before standing, and then stand before walking. Does it mean every child is going to go through this in the same sequence?
No, they can skip some train, like some kids, they don't crawl, they just walk.
They get up and go. Yeah. Does it mean anything's wrong with that child? No. I've never seen an article written yet that says that an adult was the way they were because they didn't crawl when they were a baby. There may be some out there, but I haven't seen one. So your developmental pace just means that a child develops at their own pace. They're going to do it when they're ready to do it. So if they're 6 months and you think they should have already rolled over from back to front and they haven't done it yet, It'll happen when they're ready. It'll happen tomorrow, probably happen tomorrow. It's like a little light comes on all of a sudden and they magically do it, you know? So the progress can differ by weeks or months from children of different ages. If the child progresses and develops new skills as time goes on, then they're fine. If they skip a step, it's fine too. So children skip crawling and simply begin to walk, they're fine. What is a sensitive period? Sensitive periods are periods of psychological development. The period in time of limited duration. During the sensitive periods, the child has powerful capacities. So the child can do great things and make important acquisitions, like language and movement. The first year of a baby's life is the most entertaining and wonderful, probably of all of them, because they do all these new things every day. You just can't wait to get up and see what they're going to do today. And you got your little growth chart and your little check off list of milestones. Well, today, maybe they'll do this. And, you know, it's just so exciting to watch. Speaking of infants, this is an infant. You see that sunken fontanelle on that left lower picture there? It's a little sunken. It's not terrible. I've seen worse. So you have an anterior fontanelle and a posterior fontanelle. The posterior fontanelle is the small one in the back, at the crown of the head. When does it close?
1 to 2 months or 9 a month. 4 to 8 weeks.
So like 2 to 4 months.
Posterior 6 to 8 weeks, anterior 12 to 18 months.
And then, yeah, in the front, the big one, that's the soft spot in the front. I've seen that open all the way down to the middle of between the eyes. That fontanelle goes deep. So it takes a while for that one to close. So posterior 6 to 8 weeks, anterior 12 to 18 months. And you can see here, it really is open. If you do an assessment on a newborn and you follow the fontanelle down the forehead with your fingers, you'll feel it. It's still open and approximated usually right there. My goodness, look at those eyes. Binocularity. By 4 months, the baby's eyes should be working together. This is when babies begin to develop depth perception or binocular vision. And by 12 months, the child's vision reaches normal adult levels while he's learning, to understand what he's seeing. But their muscles are weak initially, so they cross their eyes sometimes. Pain in the infant. We're going to see them crying, grimacing, that little chin quiver they get. That's so sweet. Poor baby. Eyes closed tightly and limbs withdrawn, and they're thrashing around and they're whimpering like the little baby in the bottom picture, just kind of whimpering. SIDS risk factors. What is SIDS?
Sudden infant death.
Sudden infant death syndrome, yes. So infants who are placed on their sides or tummies at bedtime or nap time, they're at risk. Using a soft or loose bedding type stuff, including quilts, blankets, bumper pads, stuffed animals, pillows, nothing should be in the bed but the baby. Bed sharing, both babies and adults or children sharing the same sleep surface, including beds and couches, puts them at risk. They can get overheated from over-bundling them. Maternal cigarette smoking during pregnancy and infants' exposure to secondhand smoke. Very high risk. Little or no prenatal care. If they've had a recent viral illness, it predisposes them to SIDS. Maternal age less than 20. Premature or low birth weight babies, male infants, and formula-fed infants. Here's some infant reflexes we need to think about. The tonic-clonic reflex. That one is like, they call it the fencing position. Can you see him holding a little sword in his hand? He's fencing. And then the grasp reflex, the step reflex, where you put a baby close to the surface of something and their little feet will start going back and forth like they're walking. The
Which one is
crawl
that
reflex,
one?
the
I'm sorry.
step reflex.
Oh, the step, okay.
Yeah. What is another name for the Moro reflex?
Parachute.
Is it Benitsky?
No, that's the startle
Oh, that's
reflex. Mhm.
Parachute.
The parachute reflex, I don't have a picture on here.
Is the other side, right? I think I'm confusing the Moro with the parachute. So this one is like a supine and you're trying to roast them, and the
Yes,
parachute is the other way.
The
They're
parachute is face down
like, okay.
because they throw
Confusing
their
both.
arms. Yeah, they throw their arms out to the side like they're a parachute falling, you know. And then Babinski reflex.
It's in the plantar of the feet.
What's the little baby in the middle doing? What reflex is that?
Sucking, trying to suck, and I think that one is the
That's the rooting reflex.
yeah, the rooting, yeah.
When you touch the side of their mouth and their mouth opens like they're rooting around for something to put in their mouth.
they trying to get it.
Here it is. The parachute reflex. Postural, not in the newborn. We see it about 6 to 9 months. We never lose this reflex. This is a survival instinct that's going to keep us safe when we fall, keep us from falling on our faces. Because our arms and hands go out in front of us, like, because we don't want to mess this up, you know? So we put those hands and arms out. That's how we get broken wrist as old people. Broken arms. So the parachute reflex, it appears about 6 to 9 months. It's elicited by holding the child in the ventral suspension and then suddenly lowering him to the couch or whatever. Arms extend in a defensive reaction. Clinical significance, absent or abnormal in children with cerebral palsy. And it would be asymmetrical in spastic hemiplegia. And we never lose it. I don't like this slide because it's not definitive enough for me in months. So I'm gonna let y'all read that because I disagree with some of this stuff. Don't refer to this slide. Toddlers. Approaching the toddler. When you're approaching the toddler to do an examination, you want to move in on them kind of close, slowly, playing with their feet or their hands and get on their eye level. So you want to stoop down and just kind of move in on them slowly. If the parent wants to hold them, let them. Be slow and non-threatening with your movements and use play to minimize their uneasiness. Toddlers and pain. What do we see with them? You're going to see changes in their usual behavior. If a toddler is in pain, they're going to probably be afraid to tell you, or maybe they don't know how to express it. But you're not going to see them playing and being their actual, happy, vivacious self. So they're going to refuse to play. They may eat less or become fussy and restless. And crying that can't be comforted, like crying and grunting or breath holding because they're in pain. So what kind of pain scale would we use? One behavioral tool is the FLAC scale. This is for children aged 2 to 7. It assesses a child's pain based on their facial expression, leg and arm movements, extent of crying, and ability to be consoled. This is all you need to remember right here. The FLAC scale would be used for 2 to 7-year-old. So according to the American Academy of Pediatrics, you want to give whole milk only after they've reached a year old, right? And remember that milk is not sufficient in iron. to sustain them. So we need to watch for signs of anemia. What would be signs of anemia?
They always be cold.
Fatigue,
Pale color.
They'd be pale. They might not be as active as they usually are. Poor appetite. Just like we see in adults when we're anemic. Cold, yeah. You get cold when you get anemic. Preschool age, delightful age. Kohlberg's moral development in this preschooler. Around age 2, the child starts to feel moral emotions and understand at least somewhat the difference between what's right and what's wrong. So with toddlers and preschoolers, they're motivated by the threat of consequences. If you bring your child up to teach them that discipline means if they do something wrong, there's going to be a reaction for that. Your child might also start to show signs of empathy. Like if they see a child or a parent who's upset, like this little girl over here. So moral reasoning develops in Kohlberg's pre-conventional level. Remember that. So the school-age child, and it's the age of Band-Aids. Preschooler. Is that? Let me see that. Yeah, preschooler. The preschooler, if they get a boo-boo on their knee and they're bleeding, they're thinking that all of their insides are going to fall out. So we need to have a lot of Band-Aids around. Ages 3 to 5 are more likely around age 4. Plenty of Band-Aids.
I was showing today, I have 2 preschool at home, and I was showing today my little secret bags.
You're prepared.
To use like 1,000 dollars in a day for real.
Yep. Yeah. It's so true. Yep. The pain scale for preschoolers might look more like this. So between ages 4 to 6, the use of several different reporting scales could be used, but we use the FACES scale a lot of times because it's easy for them to just point to the picture that how they feel. So preschool age gross motor skills.
I'm sorry, I just have a quick question.
Sure.
So is that scale for the preschoolers, is it called the VAS scale or is it called the FACE scale?
This is the long FACES scale.
FACES scale?
And I have another question regarding to the pain scale for preschooler. Because for my understanding today, you can use either one, depends on the ability of the child to, if they can rate the pain, you can make them to rate their pain, but if not, they can use either one. Oh. I think she have an internet problem.
Yeah, I think she got disconnected.
Yeah.
You still a bathtub? Is there any poop around the crib? So check, make sure it's not on the rails. All right, make sure he has a shirt on and stuff.
How you feel for this exam, guys? I've been trying to attend every single review. I've been printing everything. This is so long.
Yeah, this is my third review. I'm trying to, everybody has a different way of doing their reviews. I'm trying to get to everybody.
That's what I'm doing. I print everything. I have, I have this like a PowerPoint, but also I print like an outline version.
Yeah.
For me, this one is easier.
Yeah.
I got all her week because she sent this print out like the lesson went with the case studies and all that. And also I print the Kahoot because for me that's really helpful. Like, there was a lot of questions on quiz 1. I really didn't like it. So yeah.
Yeah.
So this look easy, but when it comes to question, they word it different.
Yeah. Good. Exactly.
Esto está muy difícil. Esto está muy difícil. Necesito otro las cosas. Aquí.
Please.
No, they can't hear me because I got myself muted. Hello. I don't know what happened to my computer.
Yeah, we can
Could have
hear
been
you
trying to do
now.
an update.
I'm sorry.
It was probably trying to do that.
We thought you froze.
You okay?
Okay, let me share my screen again and get back to where we were. Let's see what slide we were on. I'm so sorry about that. It was like I got this message and my screen just went black. It's like, what? Not now. So looks like we were about to the school age child, right?
Yeah, preschool age.
Oh, we were still doing preschool?
We were paying.
Oh, that's right. Gross
Paying
motor
for
skills.
preschoolers.
I remember now. I'm sorry, I was a little flustered, about to have a heart attack worrying about this. Okay, so gross motor skills in the preschooler. By age 3, they can walk a line, balance on a low balance beam, skip or gallop and walk backwards. And they can usually pedal a tricycle, catch a large ball, and jump with 2 feet. By the time they're 4 to 5, they can stand on 1 foot for 5 seconds, standing on tiptoes for 3 seconds without moving, without moving their feet. What happens if they say they're 3 and all they want to do is walk on their tiptoes? Is that normal?
I'm sorry,
It's
what
not.
was the question?
If they're 3 years old and all they want to do is walk on their tiptoes, that's not normal.
Wouldn't it be a sign of like autism?
It could be, yeah.
My cousin, he has autism and he does that all the
Yeah.
time. That's how he works.
Standing on tiptoes for 3 seconds without moving their feet, that's cool. Jumps forward 3 feet, jumps up onto a step approximately 8 inches high with both feet, and they can jump over a small hurdle. While running, can alternate directions and stop easily. This is the age of playing tag and chasing each other without losing their balance. And then the fine motor skills. Well, you can see here in the pictures, the fine motor skills means they're using their fingers to do something kind of intricate, like button a button, coloring, putting the Legos together. Preparation for kindergarten is very important. One of the issues that parents face is their children's readiness for preschool. There are no absolute indicators for school readiness, but children's social and emotional maturity, usually their attention span kind of gives you an idea. Do you have is preschool, well, kindergarten, they go to pre-K now, so that kind of helps them get a little more ready for kindergarten. in the socialization realm. Say you have a child who doesn't have any other siblings to play with. So, you know, they're a single child in a single family household. And so they don't have a lot of social skills. That pre-K kind of gets them ready before kindergarten. So it's important that we do that for them. Parents should promote a positive attitude towards learning. Most of these kids are ready to start learning. They're like little sponges at that age. We should try to get them ready by reading to them regularly, provide social and emotional growth opportunities, choose programs or schools that will partner with the family to foster learning, not just, you know, have them going to kindergarten as like a daycare. They need to learn something. Activities to promote gross and fine motor skills should be encouraged, and speaking to the child using full sentences promotes language. Then the school-age child, which we covered today in our lesson, is the age of the obese child. So let us remember that childhood obesity is the most common nutritional problem in the United States, and it's reaching epidemic proportion. So we should teach good nutrition from the time the child is born. Good prenatal nutrition is also important. Encourage children to exercise, not be sedentary and sit and watch too many video games and TV. Keep them active. There's increased risk of cardiometabolic changes in obese children, and educate them about diabetes at an early age. Obesity has no racial or cultural barriers, and we can't change our heredity. If it's in our heredity to have this, it's going to happen, and there's not a whole lot we can do about it, just like hypertension, cardiac disease. But we can teach them from an early age and set examples for our children. Focus on strategies for prevention to avoid complications that obesity can cause as an adult. The school-age child's same-sex peer acceptance is very important. Communicate using language that they understand. So instead of saying you're getting an x-ray of that arm, say a large camera is going to take a picture of, to look at your insides, at your bones. Well, I can't usually read an x-ray, but I can see that break in that bone pretty clearly. So this is the hypoglossal nerve that controls the tongue. And so if we're checking for the hypoglossal nerve, we're going to have them stick out their tongue. If they're old enough to move it back and forth, we'll have them do that. With the babies, it doesn't take much to get them to stick their tongue out. Just stick your tongue out at them. They'll imitate you. Lymphoid tissue growth in a child. Neck masses in children often involve the lymphatic system. This is part of the immune system, and it helps fight disease and infections. So if the lymph node, cervical lymph nodes in the neck are swollen and firm, where can we expect to find an infection?
Throat, maybe?
Somewhere close. Yeah, the throat, the ears, it would be close to that lymph node. Before birth, the fetus relies on the mother's immune system for protection from infections. But the lymphatic tissue grows steadily until puberty, and then it starts to slow down. So children are constantly fighting off new germs and infections. So their lymph system works great to respond to these antigens. Because of this response is quite common for children to have slightly enlarged lymph nodes in certain areas of the body at some times. If they're not sore and they're not inflamed, then there's no reason to suspect infection. Most will be non-palpable though, unless there's an infection nearby.
I had a question about that, about the lymph node. It's not related to the exam, but when they goes away, my baby, I think since the first week he have one, but really big and large lymph node. And they've been telling me that that's normal, but then I noticed another one back in the ear, this area right there, was tender and they told me that was normal. They, you know, they run some blood work and everything come out normal. But they should
Well-
go away by their own.
Yeah, it will. They can hold fluid too. You know, it's a lymphatic system. It runs fluid through the lymph nodes. So sometimes you can milk those and just kind of make it go away. But does the baby have ear problems or anything?
No,
No. Mhm. Did it go away?
no. I was
Not
concerned
yet.
about this one because that one I just noticed the first week, but then I noticed the one in the back. I was like a freak out because he should not have those and not even tender. So I take them to the, you know, to his doctor, and they told me they brought some blood work, but they told me that was kind of normal for their age. It should go away, but
How old is he?
3, he just turned 3.
3 years old? And he's had that since birth? Yeah, I would get another opinion about that. That's no, I don't think that's
Thank you.
necessarily normal. Dental health, brushing before bedtime is especially important. We don't want them to go to bed with all that sugar and salt in their mouth. Flossing is important, but most first graders don't have the manual dexterity to do that flossing properly, so we have to help them. Soft nylon bristles recommended for school-age children, and fluoridated toothpaste. Most toothpaste does have fluoride in it, is recommended. With the adolescents, the leading cause of death in adolescents is unintentional injuries such as car crash related injuries, followed by suicide and homicide. And this is according to the CDC. Sense of identity, we know that's what the adolescent is looking for. They're trying to rebel against the parents and find their own way and turn into the person that they're going to be. They're rebellious. They can be difficult. We have to still set limits and structures, always testing our boundaries. They're fighting for their independence and control of their environment. So this is the age of experimental stuff like drinking, smoking, trying out new things, and following their peers' leads. So talking to the adolescent about sex, we want to start with a broad statement and open-ended questions. We want to ask about their friends and their social life and kind of ease into the sex talk as you build trust and rapport with them. So you interview the teen first and then the parent. The parent and teen together with particular attention to the teen, or the parent first, if it's permissible to the teen. And what they're saying there is, if this is an adolescent appointment, we need to let the adolescent lead this appointment. You want to ask them if it's okay if you talk to the parent with them, or would they prefer that you talk to the parent separate and them separate and let them guide you in the way they want their appointment to go. So this visit should be all about the adolescent patient and allowing them to express their feelings. Give them some say in it. We need to gain their trust. So confidentiality is a cornerstone of any therapeutic relationship with the youth. Without clarifying the limits of confidentiality, you might get incorrect or incomplete information during your history taking. So allowing time for and encouraging them to express their feelings helps build rapport with the client. Respect, honesty, integrity, and ethics, all very important to get them to open up to you. Sleep deprivation in adolescents. Adolescents should get around 9 hours of sleep a night for their health. Going through changing social environment, puberty can cause problems like depression, obesity, and fatigue if they don't get enough sleep to stay healthy. Early morning classes, staying up late to do homework, or going to a football game with friends, that requires adjustment in their sleep schedule. So they have to make more time for their rest. Sleep deprivation will affect their mental and physical well-being. Health promotion should include information about getting enough sleep. This is Tanner's stages of development, showing that in stage 2, for the female, the breast buds are usually the first physical thing we see changing, and for males, enlargement of the scrotum and testes. And then we have 5 dosage calculations. I made it, yay. Thank goodness. Well, thank y'all for coming. Some of you were going to stay after class and stay with me for some dosage calculation practice. Or maybe she left. I don't know. But anybody who wants to stay after, I'll be glad to go over some with you.
I'll have to stay.
Okay.
I will
I'd love to have you stay.